Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yasin Taha from the College of Medicine, University of Suleimani, giving a talk on acute aortic dissection, clinical characteristics and outcome. You can watch this presentation and others on my YouTube channel using the URL at the bottom of the slide. Disclosure. This presentation is inspired from a recent publication of mine entitled Acute Aortic Dissection, Clinical Characteristics and Outcome, published in Journal of Emergency Medicine, Trauma and Acute Care in the year 2022 and co-authored by Drs. Mishlish, Al-Mandalawi and Alwan. Introduction. The aorta is the largest artery in the body. It consists of four parts: ascending aorta, arch of the aorta, descending thoracic, and abdominal aorta. The aortic wall is made of three concentric layers: the tunica intima, tunica media, and tunica adventitia. The tunica adventitia consists of fibroblasts within a matrix and separated from the tunica media by the external elastic lamina. The tunica media consists of smooth muscle cells and separated from the tunica intima by the internal elastic lamina, and the tunica intima is the innermost layer and covered by the endothelium. Well, acute aortic dissection is a life-threatening condition in which there is a tear in the tunica intima of aortic wall, allowing the blood to separate the tunica media layer and flow, forming a false lumen. Acute aortic dissection is one of the components of the acute aortic syndrome, which includes, beside the acute aortic dissection, other conditions such as the intramural hematoma, penetrating aortic ulcer, and ruptured thoracic aortic aneurysm. Acute aortic dissection accounts for the majority of cases of acute aortic syndrome, 95% or even more. Well, there are two anatomical classifications of aortic dissection: the DeBakey and Stanford classifications. In the Stanford classification, we have two categories, Stanford A and Stanford B. Whenever the tear in the aorta is in the ascending aorta, then this is Stanford type A, while if the tear is distal to the left subclavian artery, it is Stanford type B. In the DeBakey classification, we have three categories: 1, 2, 3, 3A and 3B. Whenever when the ascending aorta is involved, it is DeBakey type 2. When the ascending aorta is involved beside other parts of the aorta, then this is DeBakey type 1. If the ascending aorta is spared and the tear is distal to the left subclavian artery and above the diaphragm, this is a DeBakey 3A. And if the tear is distal to the left subclavian artery and the aortic dissection extends below the diaphragm, then this is DeBakey 3B. And we have also the non-A, non-B aortic dissections, which are rare types of dissections, and they refer to dissection of the aortic arch without involvement of the ascending aorta. Additionally, aortic dissection can be classified into acute dissections when the presentation is within 14 days of the symptoms onset, or chronic dissections when the presentation is after 14 days. And the acute type B dissection is also subclassified into classical dissection, ulcer-like projection, and an intramural hematoma. Acute type B aortic dissection can be either complicated or non-complicated. History. Acute aortic dissection was reported for the first time on October 1760. Incidence. The incidence is about 3 to 4 cases per 100,000 patients per year. The pathophysiology is believed to be due to an imbalance between the force of blood flow and the structural integrity of the aortic wall, rather than due to the aortic diameter per se. So aortic dissection can occur in aortas of normal size, not necessarily dilated aortas. Etiology. The risk factors are hypertension, male sex, smoking, dyslipidemia, deceleration trauma, cocaine use, connective tissue disorders such as Marfan syndrome, bicuspid aortic valve, advanced age, genetic factors, and others. Clinical features. Acute severe chest pain is the main presenting symptom. The mortality is very high and increases with time. Diagnostic workup consists of echocardiography and CT aortography. The treatment is medical treatment in the form of painkillers, antihypertensive agents, and beta blockers, and open surgical repair, endovascular repair, and hybrid procedures. All patients should receive medical treatment initially. Surgery is indicated for stand 4 type A and complicated type B. Surgery for type A aortic dissection is challenging. It should be done by an experienced cardiac surgeon as soon as possible. Surgery consists of a valve graft replacement of the aortic root and the ascending aorta, the so-called Bentall procedure. So in these pictures we can see that the ascending aorta has been replaced by a prosthetic graft, and the aortic valve is also replaced when it is diseased with reimplantation of the coronary arteries. Well, this operation, the operation for aortic dissection, was actually pioneered by Dr. Michael DeBakey, born in 1908 and died in 2008. Surprisingly, Mr. DeBakey himself developed aortic dissection at the age of 97, and he had underwent the same operation he initially pioneered and survived and died at the age of 100 years. And as the report of the New York Times mentions, he continued to practice medicine until the last day of his life. In the next slide, a short video downloaded from the internet is displayed for the sake of demonstration. The proper citation of the video is included in the list of bibliography at the end of the presentation.
Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through aortic dissection, and you can find written notes on this topic at ZeroToFinals.com/aortic dissection or in the vascular surgery section of the Zero to Finals surgery book. So let's jump straight in. Aortic dissection refers to when a break or a tear forms on the inner layer of the aorta, allowing blood to flow between the layers of the wall of the aorta. There are 3 layers to the wall of the aorta: the intima, media, and adventitia layer. With aortic dissection, blood enters between the intima and the media layers of the aorta. A false aneurysm full of blood is formed within the wall of the aorta, between the intima and media layers. The term intramural refers to within the walls of the blood vessel. Let's talk about the classification. Aortic dissection most commonly affects the ascending aorta and the aortic arch, but it can affect any part of the aorta. The right lateral area of the ascending aorta is the most common site of a tear in the intima layer, as this is under the most stress from blood being pumped hard out of the heart. There are 2 classification systems: the Stanford system and the DeBakey system. With the Stanford system, a type A dissection is when the dissection affects the ascending aorta before the brachiocephalic artery. A type B dissection refers to when the dissection affects the descending aorta after the left subclavian artery. With the DeBakey system, a type 1 dissection is where it begins in the ascending aorta and involves at least the aortic arch, if not the whole aorta. A type 2 dissection is when the dissection is isolated to the ascending aorta. A type 3A dissection refers to when it begins in the descending aorta and involves only the section of the aorta that's above the diaphragm, so it doesn't go below the diaphragm. And finally, a type 3B dissection refers to when the dissection begins in the descending aorta and involves the aorta extending below the diaphragm. Let's talk about the risk factors. Aortic dissection shares the same risk factors as peripheral arterial disease, such as age, male sex, smoking, hypertension, poor diet, reduced physical activity, and raised cholesterol. Hypertension is a big risk factor. Dissection can be triggered by events that temporarily cause a dramatic increase in blood pressure, such as heavy weightlifting or the use of cocaine. Conditions or procedures that affect the aorta can increase the risk of dissection, such as bicuspid aortic valve, coarctation of the aorta, aortic valve replacement, or coronary artery bypass grafts. Conditions that affect the connective tissues can also increase the risk of dissection, notably Ehlers-Danlos syndrome and Marfan syndrome. A Tom tip for you: in your exams, if you have a man aged around 60 with a background of hypertension who presents with sudden onset, tearing chest pain, he has likely got aortic dissection. It's worth remembering Marfan syndrome and Ehlers-Danlos syndrome as risk factors, as these may be asked in exams. Let's talk about the presentation. Aortic dissection can be difficult to spot, and the diagnosis is often missed. The typical presentation is a sudden onset, severe, ripping or tearing chest pain. The pain may be in the anterior chest when the ascending aorta is affected, or in the back if the descending aorta is affected. The pain may change location or migrate over time. Some patients with aortic dissection do not have chest pain. Other features that may suggest aortic dissection are hypertension or raised blood pressure, differences in blood pressure between the arms, and more than 20 millimeters of mercury difference is significant. A radial pulse deficit, which is where the radial pulse in one arm is decreased or absent and does not match the apex beat. A diastolic murmur, focal neurological deficits, for example, limb weakness or paresthesia, chest and abdominal pain occurring together, collapse, which is also called syncope, and hypotension or a low blood pressure, which is a late sign as the dissection progresses. Let's talk about the diagnosis. An ECG and a chest X-ray are often used to exclude other causes, such as a myocardial infarction or a heart attack, although they may be normal or falsely reassuring in aortic dissection. A myocardial infarction can occur in combination with aortic dissection, and treatment of the myocardial infarction, for example thrombolysis, can cause fatal progression of the aortic dissection. If you stop the blood from clotting and there's an aortic dissection occurring, this can cause bleeding and worsening of the condition. A bedside ultrasound scan can be used as a rapid test in A&E to look for aortic dissection. A CT angiogram is usually the initial investigation to confirm the diagnosis and can generally be performed very quickly. An MRI angiogram provides greater detail and can help with planning management, but it often takes longer to get an MRI scan than a CT scan. Let's talk about management. Aortic dissection is a surgical emergency and it needs immediate involvement of experienced seniors, vascular surgeons, anaesthetists, and intensive care teams. There is a very high mortality. Analgesia, for example morphine, is required to help manage the pain. Blood pressure and heart rate will need to be well controlled to reduce the stress on the aortic walls. This usually involves beta blockers. Surgical intervention from the vascular team will depend on the type of the aortic dissection. A type A dissection, which remember affects the ascending aorta before the brachiocephalic artery, may be treated with open surgery with a midline sternotomy incision to remove the section of the aorta with the deficit in the wall and replace it with a synthetic graft. The aortic valve may need to be replaced during the same procedure. A type B dissection, which remember affects the descending aorta after the left subclavian artery, may be treated with thoracic endovascular aortic repair or TEVAR. This involves inserting a catheter via the femoral artery and then inserting a stent graft into the affected section of the descending aorta. Complicated cases may require open surgery. Finally, let's talk about the complications. There's a long list of complications of aortic dissection. Some of the key ones to remember are myocardial infarction, stroke, paraplegia with motor or sensory impairment in the legs, cardiac tamponade, aortic valve regurgitation, and finally death. If you like this video, consider joining the Zero to Finals Patreon account, where you get early access to these videos before they appear on YouTube. You also get access to my comprehensive course on how to learn medicine and do well in medical exams, digital flashcards for rapidly testing the key facts you need for medical exams, early access to the Zero to Finals podcast episodes, and question podcasts, which you can use to test your knowledge on the go. Thanks for watching, and I'll see you in the next video.
Aim of the study. The aim of this prospective study was to reveal the clinical characteristics and outcome of medical and surgical treatments of a group of patients with acute aortic dissection admitted to Albitar Hospital for cardiac surgery, Baghdad, Iraq, over 2.5 years period in the light of the relevant medical literature. Patients and methods. From August 27, 2016 to February 27, 2019, 33 patients with acute aortic dissections were managed in cardiology plus minus cardiac surgery departments of Ibn Albitar Hospital for cardiac surgery. Some patients began treatment in this hospital but had surgery or endovascular therapy abroad. The study enrolled patients presenting within 14 days of symptoms onset. Thorough history, physical examination, and full investigations were performed. The diagnosis was based on clinical grounds, particularly the typical acute severe chest pain, and confirmed mainly by echocardiography and/or CT aortography. Intensive medical therapy, mainly analgesia, antihypertensives, and beta blockers, was immediately initiated. Aortic dissections were divided into Stanford type A, involving ascending aorta plus minus other parts, Stanford type B, confined to descending aorta, or non-A, non-B, involving the aortic arch but sparing the ascending aorta. Uncomplicated type B aortic dissections were managed conservatively, while complicated type B and all type A dissections were referred to surgery. All pre, intra, and post-operative information was entered into a Microsoft Access design database, and results collected and statistically analyzed thereafter. And that was the appearance of the switchboard of the database used in our study, and many inquiries were designed to retrieve and analyze the results. Results and discussion. As the number of patients was 33, then the hospital-based incidence of acute aortic dissection was 13.2 patients per year. The true incidence of acute aortic dissection is unknown because an undetermined number of undiagnosed or misdiagnosed cases result in sudden death and do not undergo an autopsy. However, if autopsy was performed, the prevalence of aortic dissection would be 1 to 3%. Population-based studies have estimated the incidence of acute aortic dissection to be about 3 cases per 100,000 people per year. The age and sex distribution of the patients involved in this study is shown in this table. There were 27 males and 6 females, with a male to female ratio of 4.5 to 1, which was similar to other studies. The youngest patient was 22 years old, and the oldest was 75 years old, with a mean age of 49 years. And the peak incidence was in the fifth decade, in which 15 patients, 45.5%, was observed. Although most studies state that aortic dissection occurs in people aged 60 to 70, only 18.2% of our patients were 60 to 70 years old, while near two-thirds were below the age of 50 years. The youngest patient was a man of 21. Two other patients were 22 and 23 years old. Aortic dissection is said to be unusual in patients under 40 years old unless they have Marfan syndrome or bicuspid aortic valve, etc. Bicuspid aortic valve patients are at increased risk and account for 6 to 10% of all dissections. The risk factors in this study included hypertension in 22, smoking in 14, and Marfan syndrome in 5, and these were the three top risk factors. One patient was a known case of aortic aneurysm many years prior to aortic dissection. Aortic dissection can occur in a dilated or normal size aorta. Sudden death at an average age of 40 of 1 to 2 first-degree relatives was reported 7 times. 3 patients had no identifiable risk factor, and therefore aortic dissection in these 3 patients could be due to a genetic etiology. Different jobs were involved in this study, indicating that probably there was no impact of the socio-economic class on the occurrence of the disease. Well, the clinical features are displayed in this table. Most patients had more than one clinical feature. Most patients, about 28 patients, presented with chest pain, while a few had shock, acute abdomen, stroke, or acute myocardial infarction, mostly as complications of aortic dissection. Early diastolic murmur of aortic regurgitation was heard in 57.6% of patients. Blood pressure was high in 13.3% of patients. Neurological deficits were observed in 11 cases. The duration of symptoms ranged from 2 hours to 13 days, with a mean of 4.5 days. 5 patients presented within 24 hours from the onset of symptoms. More than half of the patients, 51.5%, lived in the capital and thus had a quicker access to the hospital. CT aortography revealed dissection of the thoracic aorta in 91% of cases, and of the abdominal aorta in 51.5% of cases. All patients had transthoracic echocardiography, while transesophageal echocardiography was needed twice in 6.1% of cases. Echocardiography was very valuable and almost matched the results of CT aortography. A dissection flap between 2 separate lumens is a definite finding in diagnosing aortic dissection. ECG, chest X-ray, lab test, troponin test, and coronary angiography were also performed in some patients with variable results. So in this slide we can see CT scan of the chest revealing dissection flap in the ascending and the ascending aorta, together with a mediastinal hematoma in a patient with acute type A aortic dissection. Laboratory testing plays a minor role in the diagnosis of acute aortic dissection. White blood cell count and high sensitivity C-reactive protein are among the new tests being currently developed that may confirm such a diagnosis. In this study, the white blood cells count was high in 32-75% of cases. ECG was abnormal in 62.5% of cases. 14 patients had a chest radiograph revealing mediastinal widening in 11 occasions, 78.6%, and pleural effusion in 4 cases, 28.6%. Serum troponin was positive in 4 out of 29 cases, that is 13.8%, indicating a concomitant myocardial ischemia. Coronary angiography was done once and revealed a 2-vessel coronary artery disease. In this table, the extent and classification of aortic dissection is shown in the patients enrolled in the study. As a summary, 24 patients, that is 72.7%, had Stanford type A. 7 patients, that is 21.2%, had Stanford type B, whereas 2 patients, that is 6.1%, had non-A, non-B aortic dissection. In regard to the complications, 4 patients had renal hypoperfusion and 3 patients had stroke, while other complications such as lower limb weakness, upper limb weakness due to brain infarct, acute abdomen, cardiac tamponade, hemothorax, and acute myocardial infarction were reported in a single patient each. Complicated dissection refers to evidence of thoracic aortic rupture, organ malperfusion, or rapid expansion to a total aortic diameter of 4.5 centimeters or greater. 5 out of 7 type B aortic dissections in this series were complicated. Medical therapy was offered to all patients. However, 48.5% patients required surgery, and 3% patient required endovascular repair as well. Apart from 3, all surgeries were done in Iraq. Surgery was in the form of Bentall procedure in 13 occasions, plus an aortic arch replacement in 8 patients, and coronary artery bypass graft twice. In 10 patients, surgery was indicated but wasn't done as the patients died soon after admission. The average hospitalization period was 9.8 days, and the follow-up period ranged from 1 month to 2 years, with an average of 10.5 months. The death rates versus the Stanford aortic dissection type and the treatment methods are shown in this table. To summarize, the overall mortality was 48.5% in this series, 4 out of 16, 25% patients have died in the first post-operative week. In a few patients, the cause of death was a complication of surgery. However, in most of our patients, the cause of death was unknown as no post-mortem examination was performed. Surgical treatment yielded lower mortality than medical treatment, 37.5% versus 62.5%. Mortality of type A dissection was higher than type B dissections, 58.3% versus 28.6%. In type A, surgical treatment yielded lower mortality than medical treatment, 30.8% versus 90.9%. Complicated type B mortality was higher than the non-complicated type B, 40% versus 0%. Mortality of non-A, non-B mortality was 0. Endovascular treatment of acute type B dissection yielded no mortality. This better in-hospital survival is attributed to the less invasive nature of the procedure. Conclusions. Despite the small number of patients enrolled in this study, the survival rates of medically and surgically treated patients matched the published rates. Although surgery for Stanford type A acute aortic dissection is challenging and technically demanding, good results were obtained when surgery was performed urgently by expert cardiac surgeons. Recommendations. It is recommended to identify patients at risk of developing acute aortic dissection at an early time based on their risk factors profile. Managing hypertension, dyslipidemia, and cessation of smoking is crucial. People with Marfan syndrome need careful monitoring of aortic diameter. Aortic replacement is advised when ascending aorta exceeds 5.5 centimeter. Patients with symptoms suggesting acute aortic dissection should be immediately admitted to the ICU and receive proper medical therapy in form of painkillers and antihypertensive medications while a cardiac surgeon is consulted. A team approach is vital for successful management of acute aortic dissection cases. Once the diagnosis is confirmed, surgery should be performed for the indicated patients without unnecessary delay. Surgery is best performed by a well-trained cardiac surgeon highly interested in this form of difficult operations in order to get the best survival rates. There is a need to implement endovascular therapy in the management armamentarium of acute aortic dissection due to its less invasive nature and better in-hospital survival rates. A national database should be designed and used in the registry of all cases of acute aortic dissection in our country. And this is the list of bibliography used in the preparation of this lecture. بسم الله الرحمن الرحيم. ربنا لا تؤاخذنا إن نسينا أو أخطأنا. Our Lord, do not hold us accountable if we forget or err. Al-Baqarah 286. With this sign from the Holy Quran, I conclude my presentation. This is Professor Abdussalam Yasin Taha signing off from the College of Medicine, University of Suleimani.